Good morning, everybody. It is January 17th, 2025. Due to the flu, this is my first podcast of 2025. So, Happy New Year to everybody. I hope this 2025 treats us all well and that you all have a happy, healthy, and prosperous 2025. Today on Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association, we are joined by one of our newer members of the HCMA Recognized Center of Excellence family, and that is Dr. Wojciech Mazur from Christ Hospital in Cincinnati, Ohio. Good morning.
Good morning. Thank you for having me.
We love having you here. So I love our first meeting together.
The feelings are not shared.
It was a fun, interesting, and I don't think we quite got each other 100% on our first meeting. And I will share a little bit of insight with our listeners because I thought it was really super cute. One of the first things we do is we ask centers, what's going on in your center right now with your HCM care, and how well are you doing in terms of guideline-directed therapy? And tell me what you thought about me questioning that.
Well, I was very confident about how great we are doing because we're seeing HCM patients on a regular basis. So I assume just by sheer volume we should be doing okay. And then you started pulling feathers out of me, just pointing out that probably you're not doing a great job. And my first impression of you was, rather negative. Why are you questioning our performance? And then you suggested, you know what? Before our next meeting, why don't you pull 100 patients and look at the ACC-AHA guidelines and check it how well you're doing in terms of guidelines. Shortly after our conversation, I needed blood transfusion because my ego was bleeding permanently. But when I pulled the data, it was a rude awakening. Rude awakening. Less than 50% of our patients actually get guidelines recommended imaging, guidelines recommended follow-up. So this was a big eye opener. And we physicians have issue that we think we're doing a great job. We read our papers, we have the knowledge, we socialize with our patients, but that's not enough. And it's very important that from time to time, somebody from outside takes a look and checks on it.
And when you came back to that second meeting, you're like, I got to show you the slides. I got to show you the data. And almost to the percentage of adherence to genetic testing, Holter monitors, event monitors, stress echoes, MRIs, I'm like, you're probably going to be somewhere around here, way low. And that gives us a benchmark so that we can then go and improve. And you did the work and you brought your entire institution to the understanding that you need a focused program, and you started to structure yourself more formally. And now your adherence rate is way up here. And that's exactly what we want to see out of our centers. So I always feel a little funny about that first call because the look on your face was like, I don't like her. And I'm like, no. I'm not here to be difficult. I'm here to help you be better because that's what's right for patients. And you guys have knocked it out of the park. You guys are doing such a great job. And congratulations, you've got new office space, which was one of the other things that we discussed when we did our site visit.
Yes, we have dedicated HCM office space, which is fantastic.
I got a virtual tour just a little while ago. So if those of you who are getting your care at Christ Hospital haven't been there in a while, you might have to find the office a little bit differently than you did the last time you were there. So awesome. So the other interesting thing about you, my friend, is right after our site visit, something personally happened to you to make you definitely want to double down on your expertise as a clinician. You want to tell our listeners what happened?
Yes. So during my one of my trips with my brother, I broke shoulder jumping the waterfall. So I came back to Cincinnati, and I called my primary care doctor. Says I need a referral for physical therapy, which the doctor politely declined because told me you haven't seen me for 5 years. So not a good thing coming from a physician. Then he notifies me you have very loud murmur. My immediate answer is, I cannot have murmur because I'm a cardiologist. He had me listen to myself as OS. So, long story short, discovered that I have hypertrophic cardiomyopathy. And the symptoms were going on for probably years before. First, I noticed that I have fatigue at the end of the day, which has contributed to aging and long hours. Then I noticed dizziness when I climb stairs, and that contributed to something else. Then I noticed frequent episodes of near syncope from my gradient, which I also blew it off. Got to this point when I climb stairs in hospital, halfway through I'll get very dizzy, and to make sure that people don't see what's going on, I'll grab a phone pretending that I'm reading a message. Then I notice when I sneeze, I see stars, which I found entertaining, but again, ignore it. And only after the murmur was discovered, we did further investigation.
That was an interesting phone call when you're like, hi, this is what just happened to me. I'm like, well, we just left. Did we leave HCM behind when we were visiting? But now you're in this really unique space, and there are a few other physicians who also are HCM patients and working or running programs. I think that this is a really interesting way to connect with your patients because you have a deep understanding of the symptoms and how we normalize them and how we think that we're just normal and this is just our weirdness, but it's actually a disease state. So how do your patients react to the fact that you share a diagnosis?
Actually, very positive. Because you don't talk down to the patient, okay? So they understand that I am a physician and a patient myself, and we are partner in the journey. Okay. And I explained to him, look, I have the same symptoms you have, and I explained how I go through the day, what worked for me, what didn't work for me. I love that. And then, I assured them things will be fine. First thing, actually, when I have new patient with HCM walk into my office, and they come pretty upset with the new diagnosis, I told them, look, the data shows that the life expectancy is actually slightly higher than general population because I'm going to pamper you. We'll be fine. Okay. So acceptance is the first part.
Completely. So we're now in January. So for those who are watching this podcast at a later date, we're doing this in January 2025. And I like to take the beginning of the year to do a number of things personally, and I recommend others do it as well. What is on my healthcare list of things to do for the year? When do I want to do them? What are the logistics in terms of my schedule? Like Heart Month is crazy busy for us. So February is not a time where I like to do a lot of my personal healthcare because I'm worrying about sending out messages, right? But we want to know, I am a transplant patient now, so I have to get an echo. I have to go see my transplant team. I need to do blood work. I might need to do some other screening, cancer screenings, et cetera. That's my list for the year. And, healthcare dollars are also something that we think about. And, do I want to get all my copays and deductibles met early in the year so I'm not constantly thinking about that burden all year long? Do I want to try to wait till the end of the year, et cetera? So what do you recommend a patient with HCM have done every year? And how do you think about your healthcare spending?
So let's talk first about healthcare spending. Also, a very interesting paper recently published about financial stress of heart failure. which is kind of a similar issue. You pay the doctor, you pay for imaging, you pay for drugs. And we discovered that the stress level can cancel the benefits of medications you're taking, the financial stress.
Correct.
So think how to plan the year. So every year, we like for you to have, of course, the doctor's visit minimum once a year, your EKG, you Holter monitor, you echo. Every several years, you're going to have the MRI, and think how you're planning to pay for it if you want to meet deductible early on or late in the year. If you have financial issues, address it early on, get the patient assistance programs. The same thing with medications. If you be honest with your physician, be open and says, look, I cannot afford this medication, the copay is too high, what can we do? And very often we can do things. We can get patients grants to help the medications. So plan all those things ahead.
And don't be afraid to talk about the finances of your cardiac care. A device replacement happens every 8 to 10 years for those with ICDs. It's a big expense, but you kind of know it's coming. And you can plan for those copays, deductibles, the hospitalization, et cetera. And think about that if you have access to a health savings account, you get a little tax break there. I know that certain members of our political scheme are like, oh, just use HSAs. Well, I can only put a certain amount into my HSA because it's a percentage of your income. So it's never enough to cover my out-of-pocket expenses, but it does help. So if you can put money into an HSA, that's great. If you can't, talk to your team about patient assistance programs as they might be able to help you. And if you're not located near your center of excellence, or you need a consult with a center of excellence, remember the HCMA provides the Lori Fund, and that will provide travel stipends for those who financially qualify. So we're here to help you with that as well. But I think we need to start having more of an honest conversation about healthcare spending. I've said it before, I'll say it again, unfortunately. I have been in medical debt most of my adult life. I had a stroke and endocarditis when I was 21 years old. Had my first pacemaker at 23. All of the ER visits and all the stuff. So, there's been so much. And then obviously a transplant was not cheap, but generally speaking, it was less expensive than most people might think. So talk about the finances, talk to your team, see what options are available for you. And don't be afraid to talk about it. It is a stressor, and we want to try to minimize that.
And I would like to add, because we're dealing with patients who they no longer have insurance for some reason. It doesn't mean you will not be able to access healthcare. Please reach out to your HCM Center of Excellence, explain the situation. You will never be denied care. There's always something can be done.
We're pretty good at that. We find ways to make things happen. So let's start having that conversation. And I'm working with a number of different partners and individuals to start really looking at the burden of HCM from a financial perspective. There is no model currently existing, nor do I believe that we can create a model that actually, well, I think we can do it. I take that back. I think we can do it. One doesn't exist right now. We don't look at the cost of familial diseases. So it's not just me, the individual, that I've been taking care of all these years, right? My daughter had to get screened. My daughter needed a defibrillator at 10 and a replacement at 15. And so I have my expenses, I have my children's expenses, I have familial expenses. My dad was diagnosed and he went into HCM, heart failure and kidney failure. So we're dealing with all of these aspects of the financial implications of a chronic disease, and we're not talking enough about it out loud. So we're going to start talking more about it. And in fact, I'm probably going to be reaching out probably by mid-year to get a group of individuals who are willing to share their HCM finances with us for a research project. And we're looking at your tolls driving to and from a center, your parking expenses, your meals on the road, and all of the other little things that we just accept as part of the equation, but nobody's really quantifying it. Time off of work, paid time off of work versus unpaid time off of work. Yes, you can get FMLA, but it's not always, you're not getting your wages sometimes when you're using FMLA for the long term. So what does that mean to our families? And are we being compliant with our physician's recommendations, or are we trying to budget it and not talk about it? And that's dangerous. What do you think?
No, completely agree, because a simple thing, just a co-payment for you every 2 months echo when you use mavacamten, all those things rapidly keep adding up. And as we talk, the financial stress increases risk of cancel the benefits of medication. But simple thing, anxiety and stress in HCM significantly increases mortality, significantly increases risk of ICD shocks. So the stress will cancel the benefit of what we are doing. So plan ahead. And, I also tell my patient, if you get a huge bill, pay as much as you can.
Pay $5 a month. They can't
pay $5 a month. It doesn't affect your credit. Okay.
Mm-hmm. No, so let's talk about that for a second. So a new law is going into effect. New Jersey has had it for quite some time that medical debt can't be reported to a credit organization. And now this is a federal law. So you can come up with a payment strategy, give them their money slowly, surely. And that's pretty much what I've done my whole life. I get a bill, it's too big to pay off at one shot, and I just pay them off a couple bucks a month, and it can't count against your credit rating. So
I've seen patients who got a bill for $30,000 or $40,000, and we just laugh together. Mm-hmm. Because if your budget is $2,000 a month, good luck collecting the money,
Exactly. But if you can pay $30 a month or $20 a month, and then beat that bill down a little bit and talk to the finance department, see what you can do to negotiate it down a little bit further, and share in that planning process as well. And here at the HCMA, we're happy to talk to you about strategies as well. I'll tie into this. Okay, so I haven't really done a lot of podcasting since, the whole United Healthcare CEO thing. So there's a lot of anger towards health insurance companies right now. And I've been there, I feel it, I see it, being denied or making physicians jump through 400 hoops to go through pre-authorizations and peer-to-peers and all this nonsense.
Oh, by the way, they're making it harder to do peer-to-peer nowadays.
Yeah, and when you're doing a peer-to-peer, are you speaking to a peer cardiologist, or are you talking to, an allergy guy who's got the job of chief medical officer, or are you talking to a pediatrician versus an adult physician? They just have to have MD after their name to be a chief medical officer and to do that job, right? So don't be afraid of a denial. Fight, fight, fight.
So here is one thing which I would like to remind the patient. Ask your physician to request peer-to-peer. I grew up in a communist country in Poland, and when something was denied, we never take it seriously. You keep pounding on something until it gets done. You need to understand that most denials nowadays are computer generated. Human doesn't even look at it. So it's just rejection to keep profit for the insurance company. And the hope of the insurance company is that you will not appeal it.
Appeal. And if you need help on an appeal, call us. Call us. We will help you. We will help you strategize. We will help you come up with ways of talking to your insurance company. There's a piece going around social media right now, which is inaccurate, saying that if they deny, you just say, I'm going to go to this state and I'm going to fight you. You have to go through their process. So they're going to, depending upon the insurance company, anywhere between 10 and 35% of claims are denied up front. So then it goes in for a second. Typically it's covered when it goes back for the second, but if it doesn't, then it can go to an external review where somebody from outside of the insurance company comes in, talks to your doctor, talks to the insurance company, and then comes up with a settlement. Almost always that lands on the favor of the patient, unless it's something experimental or crazy, which doesn't really happen in HCM. So don't give up on a denial. do not give up. Call us. We're here to help you through that process. Okay, so money.
My only concern right now is that when I look at certain groups of medication, they're no longer denying, but the copay is so high. So you cannot easily appeal it because they say, look, it's approved. It's $1,000 a month, but it's approved. It's yours for $1,000 a month. So you can still appeal the reduction of the copayment.
So I'm gonna jump on a personal soapbox for a minute. So I got the flu last week, and I went to my pharmacy to pick up my Tamiflu, and they said your refill is not authorized. I haven't had Tamiflu in 5 years, 6 years, something like that. I'm like, it's not a refill, it's a new prescription. And they said, well, the insurance company denied it. And so I called the insurance company. There was a problem that they were working through. But I said, okay, what's my cash pay price? And it's going to be $109. Okay, $109. I could do it if I had to. Prefer to let the insurance company pay for it. And then they processed it, and my copay was $90, $89 and change. So what was my benefit of having insurance? A $15, $20 savings on the cost of the drug, and it wouldn't have counted towards my copays and deductibles. They're trying to push you out of using your insurance for your prescriptions. They want you to use public PBMs like GoodRx. And GoodRx is a great company, but your payments there do not count towards your copays and deductibles.
Yes.
So you're kind of getting screwed. So fight for the plan to pay as often as you can. Fight. And if you need help, we're here to fight with you because we're really good fighters here at the HCMA. So that's a little bit about cost. It's a little bit about, where we are in today's healthcare system. Don't be intimidated by it. We're all going to fight for a better system. And I encourage you all to stay tuned with us over the next couple of months as we start to evaluate where in healthcare we can really fight and make a change so that everybody has access to fair and affordable access to care. So pivoting from the annual thoughts, let's just wrap up. Every HCM patient should see their cardiologist annually. They should see their HCM center, hopefully annually. If they can't get there every year, 18 months to 2 years seems reasonable if you're stable. If you're having a change in symptoms.
If you are stable.
If you're having a change in symptoms, please get back to your center and let them help you work on those symptoms. So we've got that. Is there any other tests patients should be doing annually? Or
so in our center, what we like to do is to do 2 blood tests. One is called NT-proBNP, which is a chemical marker to see how the heart is dealing with the stress of the disease. Is the heart muscle too weak or too stiff to relax? And often those markers get elevated before patient develops symptoms. Second test I like to do is high sensitivity troponin, which is a protein which lives in the cell of the heart muscle only. So when it's outside, it tells me there's ongoing damage of the heart muscle, and I like to monitor it. So
2 blood tests a year. If you have an ICD, remember to get it interrogated regularly. We're working on a study right now with some folks up in Massachusetts on whether or not we need to be evaluating devices quite as frequently as we are. Again, the cost burden here. Do we need to do it quarterly, twice a year, annually? And does the age of the device determine how frequently you should be doing these evaluations? So we know that is a concern for some patients. My daughter just came back to me the other day and said, they're charging me $230 every time they check my ICD. I'm like, yep, cost of living with modern technology, honey. So you're going to have some expenses there as well.
Lisa, I would suggest that we do a questionnaire for physicians, asking them, how much do you think is the cost of A, B, C, D, and E? Because very often patient comes for the visit, we order gazillion tests, and some of them are unnecessary. I wish the physician would have a menu, like restaurant menu, and the patient sees the restaurant menu, says, do I want filet mignon? Or the fried chicken may be okay today.
Mm-hmm.
Just the physician also need to be aware what they're ordering.
I would also remind people that we are also susceptible to other diseases that affect other people, like cancers. So it's really important that we cancer screen early so that you can have early detection, and thereby the treatments are tending to be a little bit less invasive. We know that many chemotherapies can be cardiotoxic. So you want to look for your colon cancer, your breast cancer, prostate cancer. You want to look for your common cancers, throat, head and neck cancers related to HPV. These are really important things to check as well. Like we don't just have heart disease. We're humans who have these other risks as well. So make sure you're doing your cancer screenings. And last number on, preventative care for the year, vaccinations.
Amen.
Can we talk about vaccines?
Absolutely. So first, I wanted to tell people a cool fact. What is something called influenza pneumonia index. So influenza pneumonia index is a number derived based on the strain of pneumonia and flu. And then a government official called thousands of people across the country to find out percentage of people who are vaccinated. And with this number, they notify caskets companies how to ramp up the production. So people forget that flu kills 50 to 60,000 patients a year. Most people don't know that flu vaccination is a simple, cheapest way to prevent myocardial infarction. Flu vaccination is a simplest way to prevent heart failure exacerbation. Don't forget your RSV if you are at the age for RSV. Don't forget your COVID. Don't forget shingles vaccine. Shingles is not going to kill you, but you wish to die.
That's the one I got to go do. I keep putting it off because I know I'm going to get sick from it. I don't have time. So
do not put off vaccinations. And no, you cannot get flu from flu vaccine. It's biologically impossible. Many patients push back. They say, oh, we are being over-vaccinated. I remind patients on polio and smallpox. Smallpox beginning last century killed 100 million people. Yeah. And there were people who were pushing against smallpox because we at the time used the tissue from the cow. But the people who refused to get vaccinated, they died.
Yeah. So I don't know how something as beneficial to society as vaccinations have become somehow political. But there are still polio survivors. One of them is a dear friend, and my old boss was a polio survivor who was paraplegic because of polio. And I'm sure he would have rather have had a vaccine than living an entire life as a polio paraplegic. So these diseases are real. They're nasty. They can kill you, and worse off, they can maim you for life. So please, 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 please talk to your doctors about your vaccination schedules. And I promise this year I'll get my shingles vaccine at some point when I'm not sick. I just got over the flu, even though I had the vaccine. But if I didn't have the vaccine, guys, I was really, really, really sick for the past 10 days. I had 104 fever as an adult. Like that, it was rough. And if I didn't have the flu vaccine, I'd probably still be hospitalized. So please take care of yourselves. Your heart is an important part of who you are, but the rest of you needs to be healthy as well. So that wraps up what we think we need to do for the year and the things we need to think about and talk with our healthcare providers about. And now I want to kind of pivot into the other part of HCM, and that is the mental health components of living with this disease. So again, we are dealing with two individuals here who both professionally work in this space and have lived with HCM, most of my life, and you for the past several years. So let's talk about the mental health burden of living with a genetic heart disease.
And I'll give you my recent experience with a patient. I have a patient walking to my office few months ago, young patient in his mid-30s, a new diagnosis. Patient is not symptomatic, but a patient had MRI, which showed large amount of scar tissue. Patient has apical aneurysm. And I spent 1 hour with the patient and explained him, you will need a defibrillator, you will need a blood thinner, you will need medication A, B, C, D, potentially need surgery. And I'll explain everything in details, show the model of sarcoma, show the model of the heart, but after 1 hour, I walk out. And as a physician, you don't realize that there's a processing time.
Mm-hmm.
At first, there's a shock of information, and then you gradually, patient realize, oh, wow, I was healthy. What the guy is talking about.
Right.
So there's a really mental shock of the first diagnosis. And then you add genetics.
Yep.
And then you mention to this patient that, there's a 50-50 chance that your kids have it. And then, as you know, those of you who have kids, that something bad happened to my kid, it hurts much more than something happened to me.
Exactly.
I always ask God, don't mess with me, but don't mess with my kids. Okay. So then, if something gets detected in the children mutation, the guilt, I gave them the disease. No, you didn't. So, but it's difficult to avoid this reaction. It's completely normal reaction. This is not a reaction because you're weak. This is an absolutely normal reaction. And if you didn't react like this, you are just BSing us. You're covering the emotions. Okay. So it's very, very important to address it because, I have a patient who told me that after a conversation with you, my depression, which was in control for years, relapsed. What should I do? So it is important for the physician to immediately address what can you expect mentally.
The other part of, the first 2 years of diagnosis, it's an adjustment period. You're learning a new language. It's like you moved to a new country and like they're talking different. You didn't know these words before. You didn't know these concepts before. You didn't know this community before. And now all of a sudden we're very important in your life when we never existed before. And now you're in a Facebook group with other people with HCM and you're hearing their life experience and it's resonating with you, but it's scary and it's big and it's audacious. And you're like, what do I do with all of this information? That's common in the first 2 years. After that first 2 years, you kind of settle in, but then HCM can change.
Yes.
You can be asymptomatic or mildly symptomatic. And then all of a sudden, maybe you're developing some more SVTs or, sustained ventricular tachycardia, your heart's racing a little fast. Or maybe you have more PVCs, premature ventricular contractions, and you're feeling them more. Or maybe you've developed AFib, or maybe you weren't obstructed and now you are obstructed and your symptoms change, which then kind of bring you all the way back in that emotional journey to being newly diagnosed again. And some of them can be, 10, 15, 20, 30 years that they've like, oh, I know this disease. But do you? Because it changed on you. And that can hit you like a new diagnosis all over again.
Especially when you get ICD shock.
Yeah.
Okay. So, some of our HCM patient ICDs, hopefully they'll never go off, but the purpose of the ICD is to save your life. Should this be needed if you go to cardiac arrest? That's why the mortality of HCM is so low nowadays, because you have ICD. But we have patients who have inappropriate shocks for atrial fibrillation. We have patients who had multiple shocks. And here's a problem. When you get multiple shocks, you live in a fear of more shock, and the fear will trigger more ICD shocks.
Right.
So it's very important to seek mental health professional. There are mental health professionals in our city who are actually being trained in HCM. There are mental health professionals who deal with ICD shocks.
Yeah.
And here's something scary, but of course fixable. Chronic stress causes depression. Anxiety also leads to depression. Depression doubles the risk of death in hypertrophic cardiomyopathy. So, some doctors say, oh, this is in your head. Well, my answer is head is attached to the rest of the body. So it is in your body. It's
yes,
all
it is
connected. And my most important attitude in medicine is, what is the point of me saving your life if you live in fear and depression? I'm just extending misery. So as a physician, my goal is not only to improve your physical well-being, but to make sure that the mental well-being parallels the improvement of physical well-being.
Amen. And we provide some mental health services here at the HCMA. They are peer-to-peer. So it's not professionally led. It's peer-to-peer discussion groups. Having the ability to talk it out with other individuals who are living your same experience can remove some stress and let you feel a sense of community and let you see that your concerns are real and validated, and that we all understand the stressors of living with is a level of uncertainty related to our health. And I encourage you all to join those discussion groups. And if you need additional mental health services, talk to your team. Don't be embarrassed. Don't feel, there shouldn't be a stigma situation. We all have mental health stresses. We are all dealing with this crazy journey, and we were thrown, again, I'm going to take a step to the side for a second. The world out there is really complicated to live in, right? So we have our jobs, we have our friends, we have our family, we have all these different relationships we're trying to manage while living a life and paying our bills and living the life that we want to live. And then, oh, by the way, your heart's not normal and you might not feel good every day. And we're going to talk in a minute about cardioenergetics and how much energy it takes to just run our HCM heart. And it's a lot. It's a lot to take. Do not fear going to a mental health professional and talking about this and learning coping skills. It's not just about talking. It's what do I do when I become the cat chasing my tail because I'm nervous because my heart is racing? Well, that's not good for us.
Yes.
Because if your heart is racing and you get like anxiety triggered from it, you drop adrenaline into your heart. You drop adrenaline into your heart's going to race a little faster. And then you're going to say, oh shit, now I'm really in trouble. And you're going to drop more adrenaline. And you're going to be the cat chasing its tail. Stop. Take a step back.
So I suggest my patient, some immediate intervention, which is the square breathing.
Yeah.
Inhale on 4, hold on 4, exhale on 4, hold on 4, or 4, 7, 8. Inhale on 4, hold on 7, exhale on 8, because this can kick in within 30 seconds.
Yeah.
I also stress the importance of having a dog. They didn't do studies on HCM and dog, but they did in coronary artery disease, 30% reduction of death. Because sometimes, you go home, you look good from outside, but only the dog will recognize that you are not feeling well.
Yeah. Pet ownership of any kind. My daughter has a bearded dragon. And believe it or not, it's a cute little cuddly thing. Never thought I'd be a dragon person or a lizard person, but I really did fall in love with Haku. Okay, not so much with Yuki, but that's a whole other story. Other animals. Equestrian. My daughter's an equestrian. She has horses. And she just adopted Mr. Icy. I'm going to bring a picture up, who is a rescued donkey. So my daughter is now the proud mama of a rescue donkey. We will bring a picture of Mr. Icy up here in just a hot second, because animals are, okay, he is so funny looking. Sorry. He's a white donkey.
Oh.
Everybody greet Mr. Icy the donkey. So it was a rescue, and of course my daughter rescues donkeys and horses and goats and lizards, and she's McDonald, but McBecca. And she's a mental health therapist. So I raised myself a mental health therapist because we need more of them in the world. So
just quick scientific fact, there was a cool study on cats. They applied human definition of a psychopath to a cat, and 70% of them met the definition. Nevertheless, if you have good relationship with your cat, it will help you.
So thank you for bringing up our feline friends, because I have some late breaking news. Later this year, you are going to see the HCMA add to our website the feline HCM experience. And we have some really interesting new partners who are hoping to develop medications based on the current medications for HCM for our feline friends. And I know many people with HCM actually have cats with HCM too. So we'll be providing a little bit more insight on the feline HCM experience later in 2025.
Yeah, most common heart disease in cats.
Mm-hmm. It's very, very common.
Yes.
So I think you'll all get a kick out of that. And cats have a lot of the same symptoms as we do, but we just don't recognize it. So you're going to see some content there. So with our last about 15 minutes or so here, I wanted to talk about this concept of cardioenergetics. And 20 some odd years ago, somebody was trying to understand why they were always so tired with their HCM, while we were still trying to argue with physicians that fatigue is a symptom of HCM. And they're like, oh, no, there's no reason for that. I'm like, yeah, it's just harder to work these big, thick hearts, and it's got to take more energy. Well, now we have some science behind that. Would you please discuss ATP, what it is, how much we use, and why it might make us tired?
Yes, absolutely. So think of ATP as your fuel, as your gas. Think of HCM as engine out of fuel. Healthy heart is using 6 kilograms, I repeat, 6 kilograms of ATP per day, which if you think about it is a crazy amount.
Yeah.
But HCM heart is using 5-fold more. So it's using 30 kilos of ATP a day. But here's the problem. It sucks the energy, but the fuel lines are limited. And what is interesting with HCM, yes, you can have only one gene mutation, which should be only in myocyte, but you know what? It affects everything. It affects your vessels. Mm-hmm. So not only you don't have normal vessels, you already have abnormal vessels. You don't grow new vessels. Suddenly your engine demands much, much more fuel, but there are no fuel lines to deliver. This is how scar tissues start building up, because the myocytes start dying off. And just before our program, I talked to Lisa. We talk about just fatigue, and kind of down on me at this moment, if 30 kilograms of ATP is used to move our hearts, it's not the ATP which is generated in addition to everything else. Some of it has been taken from other resources. So no wonder I don't have anything left by the end of the day to climb stairs or wash the dishes. I hope my wife is watching it. And of course, the mental fatigue. Think of the organ which is using tons of ATP, brain. Okay, so there's a set amount of fuel in our body, and suddenly one of the organs decided to suck out all of it. Fatigue.
Which would explain brain fog.
Correct.
Why some days my mental acuity is there, and other days I just can't find the word, or I can't seem to find the solution. And I can tell you that it's almost 8 years since my transplant. The last 5 months, 6 months of my HCM heart, I had a lot of brain fog. I just could not put thoughts together. When I had this beautiful new heart installed, and I was about 5 days post-op, I looked in the mirror and I'm like, oh my God, I have all the answers to all the things that I needed to find the answers for. They were there, but they were just under this cloud. And that cloud got lifted, which was probably the biggest realization that I had, that brain fog was a real thing. And it came on very slowly. And then in advanced heart failure, it was quite pronounced. But I didn't have the energy to do anything but have my heart beat and breathe. That's what I had the capacity for at the end. And it took a long time to kind of get down to the bottom of that slippery slope. But I kind of look at HCM like a mountain, and the best you can feel is the tippy top of the mountain. and we kind of slide down the mountain a little bit and we're not at optimal, how do we stay at the top of that mountain and feeling as well as possible? I think one of the key issues is sleep. We need to sleep well. We need to rest well. We need to monitor our energy utilization and understand that if we use a lot of energy today, it may take 3 or 4 days for our energy reserves to build back up. So be kind to yourself if you're feeling tired. If you're going to be doing a big thing like an amusement park with your family, it's okay to get a scooter and use the scooter to retain your energy for the fun stuff and not expand it upon the boring walking around part. You got to pick where you're going to use your energy. What do you think?
No, I completely agree. Listen to your body is the most important message. Of course, be active. Okay, let's not forget that exercise is great for HCM. In our experience, what we noted that patients who present late with HCM, and then we dig through echoes, EKGs, you saw that they had it for many years, but they've been active all their life. They actually present later with the disease because the body adopted to lower cardiac performance.
Correct.
So don't give up on exercise, but listen to your body.
Exactly. So Elon has asked a question, Elon, about weight gain in HCM, which was the other thing that we wanted to touch on.
Yes, absolutely.
So yes, some medications can lead to weight gain. We know beta blockers are one of them. We don't want to use a medication that then brings on more symptoms and causes more trouble, but sometimes it's what we have to do. So we have to, if one beta blocker isn't working for you, you might want to try other ones that may not have as many side effects. And, the role of beta blockers long-term in HCM may change.
Correct.
May change. So that is one way to gain weight. The other way is you don't have the energy to move, but moving the fork from the plate to the mouth is not so hard. So some people find comfort in food. Try to not find your comfort in food. And in today's world, it's 2025, and we have GLP-1s. And there are a number of different GLP-1s, Wegovy, Mounjaro, what is
Trulicity, yeah.
Yeah, Trulicity. So there's all these different drugs that are now available, and I think they've been really, game changing for some people who have battled with weight. Can we discuss the use of these drugs?
Absolutely. First, I wanted to say a few things before the medication. The weight gain is not your fault. Please stop blaming yourself for weight gain. Just very quickly, there was a show on TV, Biggest Loser, and they investigate 16 individuals who initially lost 70 pounds within 2 months, and they maintained a crazy diet and crazy exercise. They keep checking them year after year after year after the year, and the weight keeps going up despite everything they did. There's something crazy going on called metabolic adaptation. The body figured out how to cut down basal metabolic rate by 600 calories. The less you eat, the less you burn, because the body thinks famine is coming. Mm-hmm. The more you exercise, the less you burn, because in the past, the purpose of running was run to get food, run away from becoming food.
Yes.
And then a discovery from 2 months ago, fat cells have molecular memory. Mm-hmm. Think of fat cells as a battery which hate to be discharged. So fat cells always want to return to the plumpest point of their lifetime. So the physician tells you, lose 30 pounds by next visit. Good luck. Good luck. Okay, so this is very, very, very difficult. Randomized studies show that lifestyle modification alone dropped the weight in 1 year by 4%. Very modest.
Very.
So let's talk about the medication. We have now 2 medications approved for weight loss. The medication are Wegovy, which is semaglutide, and Zepbound, which is tirzepatide, which are very, very effective. With semaglutide, 30 pounds, with tirzepatide, 50 pounds average weight loss. But here I have one issue with this medication. First, it's a fantastic medication. okay? Because it prevents strokes, prevents heart attacks. There are 2 studies right now published on people with heart failure preserved ejection fraction, STEP, HFpEF, and SUMMIT. So they relax the heart in people with HCM. They protect the kidney, they reduce risk of cancers, they prevent osteoarthritis. But if you lose 50 pounds on this medication without exercising, half of it is muscles.
Yeah.
And we know that especially in older population, if you lose muscle mass, death is coming.
Yeah.
So it's very important when you use those medications that you actually, I tell my patient, you know what, get some cheap gym membership and twice a week for half an hour, hit the entire machine circuit so you don't leave any muscle untouched.
Right.
You exercise all your muscle group, nothing strenuous. 1 hour per week is enough. And increase your protein intake. Normal protein intake should be 0.8 per kilogram. When you use this medication, it should be 1.1 to 1.6 grams per kilogram of your body weight. So very, very important. Otherwise, you are atrophying, you're losing muscles. So you're defeating the purpose. But the medications are taking away stigma of obesity. It's very important that physicians finally stop shaming the patients and recognize this as a disease, as a metabolic problem.
I will speak up on behalf of postmenopausal women. Most of us are insulin resistant. We're not diabetic. Most of us are insulin resistant. And insulin resistance leads to weight gain, and a lot of these medications can help to reverse that. And sometimes you don't have to go to the big ones. I started using metformin again, and it was just enough to get my insulin resistance to break. And I don't know if anybody noticed or not, but since October, I'm down 22 pounds, going back on metformin, walking more, being active, doing all the things that I was doing, but adding the metformin on top of it. And there, I finally broke through the insulin resistance. And it's only 500 milligrams twice a day.
Let's talk about the incredible action of metformin, of the GLP-1, or the SGLT2, like Jardiance, Farxiga. One of the pathways, they all work together, is called autophagy. And this is really incredible stuff. If you think of the cell, it's a tiny factory with tons of little machines, and those machines get used up. For example, the contractile unit of the heart lasts 20 days on average. And then they get eaten by inside the cell. And this is supposed to call autophagy. So the organelle gets eaten and recycled. But when we get older and sicker, the recycling stops. And the medications like metformin, Ozempic, Zepbound, Jardiance, Farxiga fool the cell that there's a shortage of food. So the cell says, I have to eat the trash first before eating the sugar. So this is one of the
cheap energy versus expensive energy.
Yes, because theoretically, like SGLT2 should work in the kidney because it's only where the receptor. But the benefits are across the entire body.
Exactly.
Forgot to mention the benefit of dementia prevention of all 3 medications.
Absolutely. We forget that Alzheimer's is actually type 3 diabetes.
Correct. It's a metabolic disorder.
It's a metabolic disorder. So we can keep our brain health functioning by getting our weight down and improving that full cardioenergetic pathway and making sure we're using good, expensive energy, not cheap energy. I do also suspect that this whole phenomena, we're talking about ATP use and weight loss, I think it explains why patients with HCM, when you eat a little bit of carb, you gain a lot of weight because we're getting that cheap energy in there and we're not getting enough protein. So protein feeds muscle. We want to feed the muscle. So keep your carbs down, your proteins up. Reasonable. So we mentioned another class of drug, and you, my dear, have a clinical trial going on at your site for the new Lexicon study in an SGLT1, SGLT2 combination for both patients with obstructive and non-obstructive HCM, one of the first trials that we've had that's looking at both populations. You want to talk a little bit about that drug?
Yes. It's a medication called sotagliflozin. It's a slightly different medication than the classic SGLT2 inhibitors, which work in the kidney, because this medication will work also in the small intestine and in the kidney. So it's kind of a dual inhibitor. And we know that this class of medication has been very effective initially in systolic heart failure and in diastolic heart failure. And so we don't know exactly how it works on the heart, because the heart really doesn't carry those receptors. But we know that it really can remodel the heart, can decrease LV mass, can improve LV relaxation indices. So the trial will use this medication. But also I wanted to mention that many of our patients are already on the older SGLT2 because they have heart failure preserved ejection fraction with great responses.
Right. So we're going to drop a link to a survey. And if you did not participate in last night's webinar with Dr. Charlene Day and Dr. Carolyn Ho, two of the PIs on this project, you'll be able to view that video later today. It'll be uploaded onto our website and our YouTube channel. And then we'll have a survey where you can answer some questions about the inclusion and exclusion criteria, and you can choose a site to participate in. There's like 17 sites that are open right now. If one of the sites on the list is not close to you, just check the box, let me know when more sites open, and we'll be more than happy to get back in touch with you when new sites open up. But if you are on Farxiga or Jardiance, it does not disqualify you from the study, but you would have to stop the drug for 12 weeks before entering the trial. And then at the conclusion of the trial, you could restart whatever drug your doctor chooses for you at that time. So being on an already SGLT2 inhibitor is not necessarily a disqualifier. That was one of the most common questions last night in the webinar. So you can still get in if you're interested. And we know that Christ Hospital is one of the clinical trial sites. So if you're in their region, you can go see the new space and visit with Dr. Mazur and Cassidy and the rest of the team and enroll in a clinical trial and help us all learn more about HCM. So I told you that this hour was going to fly, and we are
already.
We are 58 minutes in, and boy, have we covered a whole bunch of topics. So as a parting thought at the end of my first podcast of 2025, as an HCM physician, as an HCM patient and family, what are you most excited about in 2025? What do you see coming down the pike for us?
To me, one of the most exciting things is cure for the disease, especially for some mutation, MYBPC3 gene therapy.
Yeah.
And some of so far there are 4 patients who got the infusion, 3 in Cleveland Clinic, 1 in Methodist Houston recently. And quite exciting data. The company released early data showing that in one patient there's a regression of left ventricular hypertrophy. So to me, just attacking the disease at the level of the genetic mutation is very, very, very reassuring. Also, second exciting thing is, hoping to see results of cardiac myosin inhibitors in patients with HCM without obstruction.
Yes.
So many of our patients, they are not volume overloaded, not in heart failure, but they're still short of breath. And the reason is the heart doesn't relax. So when you walk, the blood from the lungs cannot re-enter the heart. You feel short of breath. If you could have effective medication which work together with SGLT2 inhibitors, this would be fantastic.
Could not agree more. So I'm looking at our list of all of the things that we wanted to discuss today. I'm going to make a final comment. Some of your stats from 2024 as an HCMA recognized center of excellence. How have you grown? I know the numbers here, but I'll let you brag on and tell everybody what great work you guys did in 2024.
So we started small. When we met first time for accreditation, we have 140 HCM patients, individual HCM patients. Now we are more than 600 patients. Last year we have over 700 visits in HCM clinic with more than 220 new patients. We have our first heart transplant in our institution for HCM, not the first transplant, but for HCM. And we have several more patients listed for heart transplant. And this is thanks to you, Lisa, because you changed the guidelines years ago. Because the argument was, oh, your ejection fraction is great. You don't need a heart.
No, we know that EF and HCM is not the leader to decide who gets a transplant. It's a factor to look at, but it ain't everything. So that is amazing work in a short period of time with a wonderful team that you have there. And my congratulations. And I'm certainly glad that our first meeting, when you went, who is this woman and why is she being so hard on me?
I would also like to give the credit to my team, to Kasali, also Dr. Bhatia. Dr. Bhatia is the heart failure specialist who is a co-director, and he took reign of the research. So I also would like to brag on Acacia enrollment. We're top enroller in the country right now. We are third enroller in Edgewise Therapeutics. So we're doing very well research-wise, thanks to Dr. Bhatia.
That is fantastic. Congratulations on all of those successes. And thank you for hearing the call before you were a member of the tribe and understanding the importance of HCM, high volume quality care, and becoming really a force to be reckoned with in the HCM field. 600 patients, when we look at what true excellence is, if you want to go and do some basic number crunching, Malcolm Gladwell wrote a book called 10,000 Hours. You need 10,000 hours in any discipline to become expert. 600 patients pretty much equals 10,000 hours of evaluating echoes, evaluating patients for heart failure, looking at all their reports. It's like 10,000 hours at 600 patients. So while most programs start in the 1 to 200 patient realm, it takes about 18 months to 2 years to get to that 600 number. You've come a long way since that first call, and the outcomes from your patients are really impressive. And your relationship with your patients as a center is something to be emulated by the other programs out there. So congratulations on all the successes. We're so happy to have you as part of our HCMA Recognized Center of Excellence family. And we look forward to future collaborations and having you back on the podcast again. So
thank you. And advice to the physicians who are starting the HCM adventure, like a song by Kendrick Lamar, humble, be humble.
Yeah.
Because despite the fact that I've been doing it for years, I'm being humbled by complexity of the patients.
Yeah.
I'm humbled by the fact that I not always have the answers.
But you're also now part of a much larger network. When you don't have the answers,
I know how to reach out.
You know how and who to reach out to, and they respond back. And we can always find answers for the most complex patients and do shared management with our other partners around the country. So on that note, we're 1 hour and 4 minutes in. I told you the hour would lie, and I didn't lie. So thank you all for joining us.
Thank you for having us.
For dropping links, and we look forward to speaking to you later in the year. Thank you.
Thank you very much.
And we are